This lecture will be beginning on chapter 25. This section is pain and inflammation management. The first part before chapter 25, the one page back, actually in the front of the unit 7, it actually has the cascade for your pain, your tissue injury pain, and the cascade of responses that your body has. Here's another picture that shows you the release, the signs, which is not necessarily infection. This is not bacterial. This is just injury that leads to inflammation, that redness, swelling, warmth, which is your body's response with the white blood counts, phagocytes, everything coming in to help you heal. And then here is another picture that goes into the actual release of different things like the COX-1 and COX-2 in response to injury. This is important because it tells you how these drugs work. So when you classify them, they'll be classified into either COX-1 inhibitors, COX-2, or combinations, or some may work in a totally different manner. And as your text says, there are 5 characteristics of inflammation. In table 25.1, the erythema, or redness, which is the first phase because that's blood accumulating to that area and dilating the area. So you have the release of, as this picture in the front of the unit talked about, and I think this picture, we go back, talked about here, the histamine kinin release, and that release includes the kinins. It also includes prostaglandins, and you will hear the word prostaglandins as we talk about some of these COX inhibitors. The histamines, and the histamine release here due to injury causes a dilation of the arteries to bring more blood supply to start the healing process. This response, which results in erythema or redness, leads to edema or swelling in the area. This is the second phase of inflammation. The plasma leaks into the tissue around the injury, so it affects surrounding tissue. The kinins dilate the arterioles, and the capillary endings are more permeable, and this is all, see the capillary leak, and the purpose of this is to lead to, again, healing. The third cardinal sign is right here, is heat. So you have the erythema from this release. You have edema due to the capillary leak, and the edema leads to heat. Heat at the inflammatory site is caused by this increased blood accumulation. And then the next fourth cardinal sign is pain, and the pain is caused because the tissue is swollen and chemical mediators are released, like over here. And then the very last, right there, the 5th cardinal sign is immobility or loss of function. And that's because all this fluid has accumulated to promote the healing process. And the pain causes you to decrease your mobility of the affected site, which actually is your body's way of allowing it to heal. So now let me again move on to this slide, which we start talking about the different sites. Here with the COX, cyclooxygenase, you'll always hear it referred to like cyclooxygenase right here, pathway, but you'll always hear them referred to as COX-1 and COX-2 when you're talking about the medications. This COX are the enzymes responsible for converting this arachidonic acid into prostaglandins. So you have this injury, and these are some of the chemical mediators that are referred to in your chart, and this leads to the release of the prostaglandins, and the prostaglandins are chemical mediators that affect vasodilation for better blood flow, relaxation of the smooth muscles to promote healing, increased capillary permeability, which is that leakage so the phagocytes and everything can get out there and promote healing, and sensitization of the nerve cells to pain. That way you have an increased pain to tell your body you have an injury, stop moving it. So it's all your body's response to promote healing. So you see here, this part of this pathway are the two COX-1, COX-2. COX-1, it tells you, are the prostaglandin and thromboxane. Thromboxane helps with the clotting. See here are the platelets, because you want to thrombose or clot to prevent further injury or bleeding. Also, these prostaglandins, very important to note here, mucosal protection, renal blood flow, and hemostasis. So when we talk a little bit on the next slide about the different drugs, COX-1 and COX-2, and how they work, we will talk about these prostaglandins and why when you inhibit the prostaglandin release, why you end up with these problems you end up with in the stomach, in the gut, intestine, in your kidneys, with your clotting. So keep in mind, this is what the prostaglandins do. So when you do a COX-1 or COX-2 inhibitor drug on the next slide, you inhibit this and it results in other problems, side effects, or damage. So COX-1, the COX-2 are the prostaglandins for the inflammatory sites, macrophages, and synovial which is the synovial fluid in your joints. Here it says inflammation, pain, and fever. So again, when we talk about COX-1, COX-2 specific, you'll understand why some cause problems, some do not. Hopefully that's going to make sense as I move forward here. So here we have that picture again with the arachidonic acid, which leads to the prostaglandin release, and the COX-1 and COX-2. This is where NSAIDs, non-steroidal anti-inflammatory drugs. They are not steroids. They are not corticosteroids, but they do cause, they are anti-inflammatories. They block the inflammatory process. That's why their NSAIDs are non-steroidal anti-inflammatory drugs. There's some that inhibit one side, some inhibit the other, some inhibit both, and then there's aspirin that's kind of out there on its own. We'll talk about some of these now, and then in some later chapters in 26 and 45 we'll talk more about prostaglandins when we start talking other aspects of pain and talking about hormonal things. So we'll get a piece now, pieces later. So these again will be terms just like everything else in pharmacology that will be carried through. The first one I want to talk to about is right down here is your aspirin. Aspirin is acetylsalicylic acid or a salicylate. Your text refers to it a little bit on page 337, and then you move over to page 338. There's an actual section titled salicylates. You have your inflammatory agents, non-steroidal. Aspirin is in there. And on table 25-2 on page 338. So your first generation was your salicylate or aspirin, which is acetylsalicylic acid. Then there's some other types of salicylates listed on your chart, but right now we're just going to stick with the aspirin up here. Sometimes you will see aspirin abbreviated at 3 capital letters, capital A, capital S, capital A, ASA. That's because it is acetylsalicylic acid. It's been around a long time, and your text says 1899. And aspirin is a prostaglandin inhibitor. that decreases inflammatory response. So if you have the prostaglandins released in here, it inhibits them, so you don't have the inflammatory response. That's how it works. And if you think too, you watch this, and people that take a lot of aspirin can have bleeding problems. If they take too much, it's metabolized through the kidney. It can damage your kidney. But see, it's blocking those prostaglandins that are protecting your stomach, intestines, kidney, and platelet. That's why aspirin is often, they'll have coated aspirin, enteric-coated, different things to protect the stomach, because it is going to, the medication itself is going to decrease the prostaglandins, which protect the stomach. So you're already at risk. And then it is acetylsalicylic acid. So it changes the acid-base balance in your stomach, makes your stomach very acidic. So it has a double whammy of one, blocking the prostaglandins that protect your stomach, plus increasing the acid in your stomach and in your intestines, leading to GI bleeds. You have prostaglandins that protect your kidney. So when you're blocking the prostaglandins from that kidney protection, you have again a double whammy with aspirin on the kidneys. Your platelets, because prostaglandins are needed for platelet formation, and when you decrease that platelet function, you have to monitor their platelet count. You'll find people that take BC powders. I'm sure you've seen packages. I've heard of BC powders. Those are so risky because BC powder is aspirin. It's acetylsalicylic acid in powder form, which means it gets absorbed very, very quickly, but it has no coating on it, so it is totally attacking that stomach and intestines and can cause very acute bleeds. You have on page 340 the pharmacokinetics of aspirin, ASA, acetylsalicylic acid, salicylate, whatever you want to call it, and of course it talks about the coated ones not crushing it, causing GI distress. It is not to be taken in the last trimester of pregnancy, but over on chart 25.1, your prototype chart, it classifies it as a category D in pregnancy. So it should not, if you think of all these issues, it should not be taken at all during pregnancy, category D. And down a little bit, contraindications, caution in renal or hepatic disorders, gout and alcoholism, labs decrease cholesterol and potassium, and your thyroid levels. It increases your pro time or your clotting time, your bleeding time. It can also increase, it can affect your uric acid levels, actually increase them, which we'll talk more about uric acid when we get to gout. On your pharmacokinetics, on that same chart 25.1, you will see that it does cross. 80 to 90% crosses over the placenta. So again, contraindicated, should not be given during pregnancy. 50% of it's excreted in your urine. It does reduce pain because it blocks that inflammation. It also responds in here on this inflammatory response, so it decreases your temperature because it inhibits that prostaglandin synthesis that is occurring up here. Side effects: anorexia, nausea, vomiting, diarrhea, dizziness, confusion, hearing loss. Aspirin toxicity is ototoxic. It causes a ringing in the ears and can damage the hearing. Also very important under your adverse reactions: tinnitus, which is ringing in the ears; urticaria, which is that itchy on the skin; ulcerations, which is stomach, GI bleeding, stomach and all the way down the intestines because of this blockage here of prostaglandins; life-threatening agranulocytosis, hemolytic anemia. Just think of it, thrombocytopenia. Think of it as blood dyscrasias because it affects your clotting time. Thrombocytopenia is a platelet count under 150, so you have low platelets from right there and can lead to bleeding. Reye syndrome, which is, your text talks about it somewhere. Where did I see it? On your pharmacodynamics on page 340, I think. Because it's Reye's syndrome happens in kids. It should tell you somewhere not to give it to children. You see. Found it. It's on the pharmacokinetics section on page 340. Just saw it. Aspirin should not be taken by children with flu symptoms because it may cause potentially fatal Reye's syndrome. And when we get into pediatrics, we will talk more about Reye's syndrome, but that's why you don't give aspirin. Not just flu symptoms, you just tell them under the age of 18 or under the age of 16, no aspirin. Okay, so here is some common non-steroidals. Your text, I believe, lists, see, your aspirin is listed in there. I believe your text talks about all of these. And these are selective. These are ones that specifically work on, I believe this is all the COX-2 inhibitors over here. They don't do both, so you don't have these problems with COX-2 only inhibitors, and I'm going to talk more about that. So on your chart table 25.2, go down to no, I don't think I'll approach it that way. An easier way for you to understand it on the top of page 340 is a wonderful figure 25.1. It shows you the COX-1, the COX-2, where aspirin and nonsteroidals block both the COX-1 and COX-2, and then there's the specific COX-2 inhibitors that only block this side, so they don't have all of these effects. All you really need to keep in mind, all of these over here are blocking COX-1 and COX-2, so they all have the potential for all these problems plus this. The selective nonsteroidals, these are all, you see they all end in almost the same thing except for meloxicam. It wants to be the oddball out. A lot of these have the Profen, and these you're just going to have to learn them. And these over here, the COX-IB naming it, or this has the Oxycam, I guess is how you can think of it, when they have that COX part in it, that they are COX-2 inhibitors selective, so you don't have the bleeding gut problems with it. Do look over table 25.2, just getting familiar with most of them that you see in the top. The propionic acid, there's quite a few work that way. And if you look over on the propionic acid, all of those are category C, pregnancy category C, and they're all category D during pregnancy. If anyone has been pregnant, knows someone, actually, if you keep going down, everything's a C with a D in the third trimester, but the rule of thumb is no nonsteroidals, aspirin, any of these drugs when you're pregnant. It's acetaminophen, which is Tylenol only. None of these drugs at all during pregnancy. You again have the nursing process. It starts on the bottom of page 340, goes through to the top of 342. Talks about the gastric irritation, about bleeding, monitoring, serum salicylate, aspirin level. Unless they're on this really, really high dose, you don't usually monitor that level. But the mild toxicity occurs at a certain range. They might draw it if they're concerned about it, especially if there's an overdose or if they're having severe signs of bleeding gums, petechiae, which is those little red spots, ecchymosis, which is them bleeding, bruising very easily, large red spots. Patient teaching, not to take aspirin with alcohol or with drugs that are highly protein bound, such as anticoagulant warfarin, because the aspirin is highly protein bound, which will make more of that drug, such as warfarin, which is your good old Coumadin, those levels higher. So if you were asked a question about it and they were taking aspirin and they were on Coumadin or warfarin, you want to do their PT-INR frequently and tell them not to take acetylsalicylic acid or aspirin. One thing I want to point out when it comes to over-the-counter drugs, people don't realize that some things have acetylsalicylic acid in, which is Pepto-Bismol, which is over-the-counter for GI issues, for stomach issues. So no Pepto-Bismol. No Pepto-Bismol for anyone under the age of 16 because of Reye's syndrome. And what is the other one? Excedrin. Excedrin comes in multiple things. There's Excedrin that is ibuprofen. There's some that's ibuprofen and acetaminophen. So it's a non-steroidal and a Tylenol. And there's some that has caffeine in it too. So those are things that if somebody is put on a prescription non-steroidal, like one of these, that they cannot take things such as aspirin. Such as Excedrin. So many people will be on prescription diclofenac or ibuprofen, or they're taking Aleve, which is a brand name, over-the-counter name for naproxen, and they don't realize that they can't take Aleve and take ibuprofen, or they might be on indomethacin or diclofenac prescription. They may be getting it like diclofenac comes in a gel. Some of these do come in a gel form, and they're not thinking of it as a pill. So major teaching for the nurse. And see on page 342, the parachlorobenzic indomethacin, again, is protein-bound, inhibits prostaglandins, but it's all on your list. I'm going to let you read over this. I'm not going to go into all of it. The propionic acid I talked about, that's your ibuprofen, highly protein-bound. So just think of the same rules on all of these, the protein, the prostaglandins, the bleeding, all that stuff. Okay, so nursing process for ibuprofen starts on page 343 to 345. Really the same things you're looking for. One thing in there on your patient teaching, there's lots of the little lightning bolts. Really look over that. Look for that herbal alert, 25.1. A lot of herbs that interact and cause bleedings, especially when they're combined with non-steroidals. Major teaching again for the nurse, and warning the female not to take non-steroidals 1 to 2 days before their menstruation. Avoid heavy menstrual bleeding. There is a prototype chart 25.2 for ibuprofen. Notice the CD pregnancy, but I said that on all those non-steroidals. Then we get over to the specific COX-2 only over here, the big one, celecoxib, which you may have heard of as Celebrex. It's the most common, the COX-2 that you will find. Sorry, I want to clarify the celecoxib, or what I know as Celebrex, is the only specific COX-2 only inhibitor. These others are very selective, and as your chart in table 25.2 talks about, these rest of these, the ones you will see the most is the meloxicam, and it is mostly COX-2 selective. So you may have some issues over here, but it leans mostly to the side. But the celecoxib is the only true COX-2 only inhibitor, and somebody with a history of GI bleed or ulcers that really needs to be on a anti-inflammatory, or they have a cardiac history and they have to take aspirin, or they have to take a drug to decrease to make their platelets slippery because they have a stent or something in, and they need an anti-inflammatory, maybe put on this to avoid doubling these effects over here. I'm going to move on here. I found this picture I thought was just great for a way to put it in your mind and thinking. And said, Jim, no pain, no flame, and no heat when we meet. Analgesic, anti-inflammatory, antipyretic. 1, 2, 3, 4. Oof, that's all I can do in one day. In dosing is what it's reminding you of. Like, the max dose for ibuprofen for the day, these non-steroidals. Watch out for GI distress, dizziness, rash, heartburn, and occult blood loss. Okay, enough said about NSAIDs. Oh me. That's all I can do for one day. So it's talking about some of the non-steroidals are 2 doses a day. Some of them are classified as 4 times a day. So that should help you. Here we go on corticosteroids on page 344 on the bottom. It starts talking about corticosteroids, which is prednisone, prednisolone, and dexamethasone. They're anti-inflammatories, and they're not non-steroidal, they're directly anti-inflammatories. And this is a good picture to show you when you have the injury and the release. It blocks everything from happening. Very intense inhibitory response, blocks everything. We're not going to go into it a lot in this chapter because there will be discussing it later in chapter 51. Half-life of corticosteroids is very long. It's more than 24 hours, which is why the dosing is once a day. I know there's dose packs that have 6 tablets a day, 5 tablets, 4 tablets. It tapers down. For some reason, those things say to take the 1 pill 4 times that day, which I always tell people you take it 1 time because it's a 24-hour length. So you take it once a day, and never, if they were on it more, they used to say you always had to taper, but they've learned 5 days, if you're on it more than 5 days, then you need to taper off. But what you need to remember, corticosteroids, never a sudden stop, always has to be dropped, and we'll talk much more in a later chapter. So then we get into the DMARDs. All DMARD stands for is disease-modifying anti-rheumatic drugs, DMARDs. You can see here it talks about Rheumatrix. That's these are brand names. So here your Plaquenil is hydrochloroquinolone. Let's see, prototype. Chart 25.4 on page 347 talks about infliximab. Notice it is safe in pregnancy as a category B. It is only given IV over a 2-hour period. It's used for rheumatoid arthritis and Crohn's disease. Crohn's is a terrible inflammatory disease throughout the entire intestines. Contraindications, the hypersensitivity, heart failure, caution in renal or hepatic dysfunction, bone marrow suppression, immunosuppression, multiple sclerosis, seizures, and older adults. The way these DMARDs work is by making changes in your immune response. So this interleukin receptor and the tumor necrosis factor, or TNF, it blocks them to modulate or adjust or change your immune response with disorders, diseases, disorders that affect that are caused by the immune system, causing this inflammatory response in your body. And rheumatoid arthritis, Crohn's disease, many things are caused by this. So let's see, there's DMARDs table 25.3, goes over a few of them. Trying to think of which ones you really should learn. That adalimumab, which is Humira, that's quite common. Infliximab is another That's fairly common. Looks like the majority of them end in a MAB, M-A-B, so and or CEPT. I would remember those as DMARDs affecting your immune system. Most of these are category B in pregnancy. There's a couple that are category C, but nothing's a D or an X. You have the nursing process for infliximab on the bottom of page 346, 347. A few things. It's look at your assessment where it says asking the patient about seizures, diabetes, multiple sclerosis, kidney or liver, and about aspirin. Renal and liver function tests have to be monitored. Those diseases are because of the way the DMARDs work in affecting or impairing, slowing down, blocking things in the immune system. You see under nursing interventions the labs that you want to monitor, which your CBC, which is your complete blood count for your blood discrepancies, dyscrasias, your liver function, which is your AST, ALT, alkaline phos, that's what your ALP is. Your renal labs, RUBUN, and serum creatinine. Flushing real well, giving over at least 2 hours, which is very rare to see a drug go that slow. Side effects, teaching the patient what to report, which are all things on affecting that immune response. I think that's it on these. Antimalarials, it has a little blurb on the bottom of page 347, which really doesn't go into in your text. That's one of them, the hydrochloroquinolone or Plaquenil, which is listed here, is actually an antimalarial drug that can be used but takes quite a while for it to work and is often used in combination with others for unresponsive inflammatory disorders. So now we're near the end of this chapter. We're going to get into the gout. I found this and I thought it was just perfect to help you. I am anti-gout. I sing, I give my action to decreasing uric acid and stopping pain is my thing. I block renal uptake of uric acid. I inhibit inflammation and reduce pain and swelling. I decrease uric acid by interrupting production. And then in your red, which hopefully you can print and see this better on all the different gouts, anti-gout medications, how they work. Gout of there, hey, just a little play on words. Anyway, so on your gout section, which begins on page 348, it's referred to as gouty arthritis. It's an increase in uric acid. Some people just have a propensity for it, and a lot of it is foods that are high in uric acid. So the few foods that are high in purines, which increase the uric acid, are organ meats, like liver, sardines, a lot of the red meats, salmon, gravy, herring, there's liver, meat soups, and alcohol, especially beer. They should be avoided because it increases your uric acid production. Acetaminophen should be taken for discomfort instead of aspirin because the salicylic acid is so acidic, and you want to decrease that acid production. Anti-inflammatory gouts, colchicine inhibits the migration of leukocytes, which is a type of red blood cell, to the inflamed site. It is not for chronic use. It is just given for acute symptoms. It's usually given like 2 times, certain times, a certain number of hours apart. You take it one day, you take it that evening, then you take it again the next day, and that's all you take, and then you cannot repeat it again for 7 days. It's just for acute bouts, not chronic use because it does not inhibit uric acid synthesis, and it doesn't promote getting rid of the uric acid. So it's just to help with acute attacks. And note here, it should not be used with people with severe renal, cardiac, or GI problems. Those are contraindications. Gastric irritation is common, so you teach them to take it with their food. It's well absorbed in the GI tract and excreted in your feces, majority in the feces and the stool. Uric acid inhibitor, allopurinol, which is the most common one you'll see out there that people will take on a chronic daily basis to help them break down that uric acid, and by doing that, breaking it down, excreting it, they prevent the attacks. It is the drug of choice for preventing gout, and it can be used in those with gout that have renal impairment or renal obstruction. Your chart 25.5 on page 349, you want to look that over, look at all those drug, lab, food interactions. There's quite a bit listed there. Contraindications, you want to look at its category C in pregnancy. On page 348, you know that the protein binding is unknown, so use some caution if they're in a other drug that is protein bound, because you don't know. It inhibits production, it increases the breakdown. Alcohol, caffeine, thiazide, diuretics increase the uric acid levels. Use of ampicillin or amoxicillin, which are penicillin drugs, with allopurinol increase the risk for rash formation. Allopurinol can increase the effects again of warfarin and oral hypoglycemic drugs. So that's in the bottom of your pharmacodynamics on page 348, that it would certainly put that in your brain. Uricosurics increase the rate of uric acid excretion by inhibiting the reabsorption. The big one for this is probenecid. That's the one you will see the most. And note on it, it is 95% protein bound. So again, you're going to use caution when they're on other meds that are protein bound, such as your warfarin or Coumadin. Sometimes they will be on allopurinol to keep their levels low, to keep them from synthesizing the uric acid, and they may be on, and non-steroidals such as indomethacin is the one you'll see most commonly. But the uricosurics or probenecid help you excrete it, where the allopurinol helps to decrease the synthesis of it, and your colchicine strictly works to stop that inflammation specific to this, but it doesn't affect the uric acid. So you have the nursing process and allopurinol, bottom of 348, and continues over to the top of page 350. Make sure you look at the laboratories that you need to watch, which is your liver enzymes, your LDH, and your BUN creatinine, which is your kidney. Down to nursing interventions, there's a couple of lightning bolts monitoring the labs, which is the renal and the liver function test. BUN creatinine, ALP, which is alkaline phosphatase, AST, and ALT, which are specific to liver. And I think I covered that. Hopefully you can read these and put that to mind. And here we go. So this is the end of chapter 25 lecture, and you will continue on to chapter 26 lecture on non-opioid and opioid analgesics.